How do you want to treat acute severe asthma? You want to give steroid or you want to give beta blocker? I mean, do you want to give salbutamol? And you want to give only salbutamol or you want to give it along with nebulized oxygen? Give it with oxygen. Otherwise, if you give only salbutamol without nebulizing it along with oxygen, patient can worsen. What is the reason? Because ventilation perfusion mismatch will be worsened. Because your bronchodilation will open up to those fields which are not well perfused, so that can worsen. So always give along with the oxygen the the salbutamol is the golden rule. So let's go to the next question. Disulfiram-like reaction is typically seen in which condition, which case, doctor? Cifamandole and metronidazole along with the alcohol, you should not forget. And all that list of drugs, please try to recall for your tomorrow's exam. Churg-Strauss syndrome. Can you tell me what is the closest differential diagnosis for Churg-Strauss? Bronchial asthma. So patient can come with asthmatic episodes along with the vasculitis. You need to think of it. So it is idiopathic multisystem vasculitis. Peripheral eosinophilia is the rule, and the skin and the lungs are most commonly affected. And in this case, it is the steroid plus cyclophosphamide is considered to be the treatment, not the radiotherapy. One question invariably comes, doctor, whether it is Wegener's, polyarthritis nodosa, or the Takayasu's aortoarthritis, or from the Churg-Strauss. You can't escape. You have to review it as a part of the medicine questions for this entrance. Hypocalcemia is not a feature of the vitamin D intoxication. It is seen the vitamin D deficiency is the basic rule, which you should not forget. Cardiomyopathy is typically a feature of deficiency of carnitine, thiamine, what is that called? Wet beriberi, dry beriberi are there, no? And selenium toxicity also. What is that condition called? Keshan's cardiomyopathy. Excellent, excellent. So let's go to the next question. Head injury commonly presents with what? Altered consciousness is much more a common feature. Fat embolism is not seen with liver injury, with long bone injury is what it is seen typically. Lipiguria is another important feature. Where do you find leukoerythroblastic picture, doctor? Typically, you find it in the case of myelofibrosis, Gaucher's, which is infiltrating into the, what is leukoerythroblastic picture basically? Once there is an infiltration into the bone marrow, any condition leading to a diffuse bone marrow fibrosis, that all lead to a leukoerythroblastic like picture. So a bone marrow shows extensive necrosis with a lot of metastasis occurring into the bone marrow in this. So a leukoerythroblastic picture is seen in the case of myelofibrosis, Gaucher and secondary malignancy of the bone marrow. What is a striking clinical sign in the case of the myelofibrosis, doctor? Massive splenomegaly will be there. What type of cells will be there? Teardrop cells will be classically found. Why teardrops? Generally bone marrow will nicely apply powder and then nicely create the bride and then sends into the blood. But there is no time. Spleen is like sasural. So once bone marrow is not functioning in myelofibrosis, extra marrow hematopoiesis will be occurring in spleen. Hence it become enlarged. But sasural may you won't have all that privileges. Go to the office, whatever you are. So it has to run whether it is well dressed or not. So that unkempt dressed RBC is basically the teardrop that you see in the peripheral smear in the leukoerythroblastic situation is what need to be remembered. What are the complications of the splenectomy, doctor? It can lead to recurrent infection, fulminant sepsis and DIC. So this kind of simple questions also will come. You need to answer them. So what is the action of the lactulose in the hepatic encephalopathy? It basically decreases ammonia production. It prevents the incorporation of the ammonia. It has nothing to do with amino acid absorption. And what is true in a child with a lower UTI? Is it more common in male or female? Yeah, so maybe what you call VUR, vesico-uretral reflex is more common in male. Is it exclusive for males? Posterior urethral valves. Check it. So VUR is an associated feature. Nothing like male are more commonly predisposed is what need to be remembered. IGR term baby can have the problem of intraventricular hemorrhage. What is the feature of the hypothyroidism, doctor? Bone age and height age will be differing from each other, but otherwise short stature, delayed milestone, delayed dentition, the teeth eruption, all these things are the classical features. In Fabry's disease, what is the enzyme deficient? What do you see in the case of the McArdle's disease? Yes. So among this, what is the answer? Ceramidase? I mean this hydrogenase, Hurler, Hunter, mucopolysaccharidase, all these von Guy's glycogen storage disorders, and also these disorders. Please make it a list and revise, because one question you can't stop it. And Churg-Strauss syndrome, typically with the hypertrophied calf muscles, with the associated hypothyroidism, classically you see in pediatric population. So in them, the muscles hypertrophy, the skin appendages, there is a coarse hair which will be seen here, and endocrine system there is a hypothyroidism, and the mouth and oral structures there will be a macroglossia with a delayed dentition, and the characteristic facies is unforgettable, and there is a growth retardation and also mental retardation, and clumsiness and awkward gait, they're all the classical features of the Churg-Strauss syndrome should be remembered. What is the feature in the tuberous sclerosis, which is the earliest feature? Ash leaf spots are found, periungual fibromas are found, shagreen patch is also found, all of us we read. But which is most earliest? See, the thing is, tuberculosis you can tell all those things. Tuberous sclerosis, how many have seen? Can raise the hand. Seen? Good. So, then that is always good. But all are not privileged, that to see the first patient and that to first sign the sign and all these things. So you have to mug them like a quiz show and answer it in the tomorrow's exam. So the earliest manifestation of the tuberous sclerosis. Okay, if you take the tuberous sclerosis, typically there can be cardiac involvement, but it is maximal in the case of the prenatal life or infancy. If the tuberous sclerosis patient is presenting in infancy or childhood, then seizures, autism and developmental delay become the manifestations. When will Ashleaf macules will appear? They appear from the birth, but frequently are unrecognized. Shagreen patches usually appear in childhood to early adolescence. So, by all this, let us also talk the remaining things. Renal lesions, that is with the hypertension, renal failure, polycystic kidney disease, all these things will appear in infancy or the early childhood. And they can develop AML and hematuria, retroperitoneal hemorrhage, abdominal mass and all these things can appear at a later point of time. And pulmonary involvement can occur between second to third decade with dyspnea and pneumothorax and chylothorax, and it can be misdiagnosed as emphysema. And finally, dental development can be there with the gingival fibromas. Now, by considering all this logic, we can see that the Ashleaf spots are present from the birth. So obviously, earliest manifestation must be Ashleaf. And shagreen patches are typically present and angiofibromas are appearing in childhood or in early puberty. Hence, they can't be the earliest manifestations. And that is all the story. So, Ashleaf's macules typically have got an appearance like this in tuberous sclerosis. They are the hypopigmented macules that you find. And you can find the facial angiofibromas which can occur in a patient who has got the tuberous sclerosis. And there can be development of a cortical tubers which can develop, which can lead to the development of seizures as a clinical presentation is what I want to underscore to all of you. So what is the combination of the increased HbA2 and HbF is a feature of? Basically, beta-thalassemia minor, you find an elevation of the HbA2. In this, there will be a normal red blood cell count. Basically, HbA2 has got 2 alpha globin genes which are complexed with the 2 delta globins. If you take the beta-thalassemia minor, this elevation of the HbA2 is one of the important clinching part in the diagnosis when you do the what you call electrophoresis in a given case of the beta-thalassemia minor. Whereas if you take the beta-thalassemia major, typically there is imbalance of the globin chain synthesis, and the beta chains are not well produced, alpha chains become precipitated, that lead to the development of the ineffective erythropoiesis with the development of the microcytic hypochromic anemia is what I want to underscore to all of you. So beta-thalassemia minor would be a very good answer for this. Let's go to the next question. Epistaxis is there, platelet count is normal, but the bleeding time is prolonged with the APPG prolonged. APPG prolonged means what is the reason, doctor? Factor 8 is prolonged. But can we call it as hemophilia? We can't call. Why? Because bleeding time got prolonged. But can we call it as ITP? Idiopathic thrombocytopenia purpura? We can't call because platelet count is normal. So it must be some platelet functional disorder. Now what are the 3 platelet functional disorders? Bernard-Soulier, von Willebrand and Glanzmann's thrombocythemia. Excellent. Out of these 3, which is the one which also causes APPG prolongation? It is a von Willebrand, because factor 8 is required, von Willebrand factor is required to maintain the stability of the factor 8. If that is deficient, factor 8 will become broken down very fast. That leads to APPG prolongation. Why the bleeding time become prolonged, doctor? If the von Willebrand factor is not there, one plate cannot adhere with the other. So that is the reason there is a problem that will be happening, is what need to be remembered. Okay? So now you are sure the answer is von Willebrand's disease. Thank you.